Okay, okay. Uma sir is also there.
The renovation is going on, so in the same room. Just we are connecting.
Okay, okay.
Muralidharan sir, good morning, sir. Yes, sir. Oh, Mangesh sir is also there. Good morning. Good evening. Good morning. Yes.
Sir. Hello. Vinod, I am audible.
Yes, Baiju, audible, but there is an echo. Is there anyone else using a laptop in the same room?
Yeah, all are in the same room.
That's the problem. Like if everybody is
Yeah,
on.
that will mute. Okay. Mail.
Namaskar. The new year brings a fresh ray of hope in the form of COVID-19 vaccine. The vaccine made in India under
സാറേ 9th എന്ന് പറഞ്ഞ് നമ്മൾ വേറൊരു ഇത് കൊടുത്തു സൂം ഏതിൽ കൂടെ സാറ് കയറുന്നത്? സാറ് ഏതിൽ കൂടെ കയറുന്നത്? ഇന്ന് ഞാൻ വേറൊന്നും അയച്ചു തന്നിട്ടില്ലേ ലേറ്റസ്റ്റ്? ആ അത് ഡേറ്റ് നോക്ക് 9th ആണോ നോക്ക്. 9th എന്നും പറഞ്ഞ അത് തന്നെ അതിന് മുന്നേ ഒരു ദിവസത്തെ ഉണ്ടായിരുന്നു. അത് നടക്കാൻ 9th എന്ന് പറഞ്ഞിട്ട് മാറ്റിയിട്ടുണ്ട്. രണ്ടാമത്തെ നോക്കണം. അപ്പൊ ഒന്ന് പുറത്തോട്ട് ഒന്നുകൂടെ ക്ലിക്ക് ചെയ്താൽ വരും. ഓക്കെ, യു വിൽ സ്റ്റാർട്ട് നൗ. സ്റ്റാർട്ട് ചെയ്തില്ലേ? ഞങ്ങൾക്ക് ഒരു 2-3 minutes യു വിൽ സ്റ്റാർട്ട്. അല്ല, ലിങ്ക് യു ക്യാൻ എൻ്റർ. ലിങ്ക് ഓൺ ചെയ്ത് ടോക്ക് തുടങ്ങിയില്ല എന്നുള്ളേ ഉള്ളൂ. ടോക്ക് ലിങ്ക് ഓപ്പൺ ആണ്. ടോക്ക് സ്റ്റാർട്ട് ചെയ്തില്ല. എന്റെ നായർ സാർ,
Hello, sir. Neil.
yeah, Rajesh is there. Just wait 2 minutes. We will. ചെയ്തില്ല. അനൗൺസ് ചെയ്ത റെസ്റ്റോറൻറ്റ് എല്ലാവർക്കും 6:10 സ്റ്റാർട്ട് ചെയ്യുമെന്ന് പറയും.
Hi, good evening. Okay, we will begin within another 2 to 3 minutes.
ക്ലിക്ക് ചെയ്താൽ മാത്രം മതി. ക്ലിക്ക് ചെയ്താൽ മാത്രം ആ ലിങ്ക് ഡേറ്റ് 9th ആണ്. ഡേറ്റ് 9th നോക്കണം. അന്നേരം പറഞ്ഞു കൊടുത്താൽ മതി. സ്റ്റാർട്ട് ചെയ്യാൻ നേരം സ്പീക്കറെ നോട്ട് ചെയ്തു. ഓക്കെ.
Hello.
Yes, sir. അത് പറഞ്ഞു സാറേ. അല്ല, 9th അകത്ത് ആ ബ്രോഷറെ ക്ലിക്ക് ചെയ്തോ? ബ്രോഷറിനകത്ത് ആ ബ്രോഷറിനകത്ത് ഫീമെയിൽ ഇല്ല. ബ്രോഷർ മറ്റേതിനകത്ത് ആ ബ്രോഷറിനകത്ത് ബ്രോഷർ നമ്മൾ വാട്സപ്പ് ചെയ്തിട്ടുള്ളേ ഉള്ളൂ. ഞാൻ നോക്കാം. ഇതിനകത്ത് സ്റ്റാർട്ട് ചെയ്തു. സ്റ്റാർട്ട് ചെയ്തു.
Good evening. A warm welcome to the webinar on the topic My Tryst with blood vessels, the diseases and biomedical by Dr. M. Unnikrishnan. Jointly organized by IEEE MBS Kerala Chapter and IEEE ILIAC Kerala Section. With great pleasure, I welcome IEEE live members, fellow members, senior members, members and student members, members from IEEE MBS Kerala Chapter, members from IEEE ILIAC Kerala Section, and everyone who joined us this evening for the webinar, jointly organized by IEEE MBS Kerala Section and IEEE ILIAC Kerala Section.
You are not audible, please. You are not audible. You are not audible.
for introducing the speaker. Mr. Vinod Kumar, please.
Warm good evening to all of you. Am I audible now?
Vinod Kumar, you are on.
Am I audible now, Baijiji?
Yes.
Okay. So, very good evening to all of you. I'm extremely happy to introduce today's speaker, Dr. M. Unnikrishnan, to all of you. Dr. Unnikrishnan is a head of vascular surgery at SUT Hospital, Trivandrum, Kerala right now. Dr. Unni has completed his MBBS in 1975 and MS in General Surgery in 1978 from Jipmer, Pondicherry. After that, he has done his MCH in Cardiovascular and Thoracic Surgery in 1985 from Sri Institute for Medical Science and Technology in Trivandrum. After his MCH course, he has held various positions in Sri Cittaranal Institute, head of the division of vascular surgery for a long time, and established an MCH program in such as cardiac science in the institute, and ultimately he has retired as a senior professor of cardiovascular and thoracic surgery from SCT. He had multiple national and international level activities like reviewer of European Journal of Cardiovascular and Thoracic Surgery, Indian Journal of Vascular and Endovascular Surgery. He was also an examiner for MCH vascular surgery program in many universities. And being a member of Board of Specialty Vascular Surgery in the Medical Council of India, prepared national syllabus for MCH program in vascular surgery for MCH. And he was also an inspector for MCA for many years. And Dr. Unni was also the president of Vascular Society of India from 2019 to 21. Dr. Unnikrishnan has also received many awards and recognitions like MMC Vascular Alumni HT Veera Reddy Oration 2011, prestigious Godrej S. Karai Oration of Indian Association of CVT Surgeons in 2014, Dr. B.C. Roy National Award in 2016 in the category of Eminent Medical Teacher. Unni sir is also having around 100 publications and 4 book chapters to his credit. And for us, scientists and engineers, Unni sir's contributions in technology development is more important. So he was part of a team developed indigenous large diameter vascular processes, having completed the multi-center clinical trial. And he was also the chief coordinator and clinical investigator for development of small diameter vascular graft aortic stent grafts. And his current research activities include development of small diameter vascular graft and development of aortic stent grafts. So with this, sir, you're muted, you're not audible.
Hello, am I audible now?
Yes, sir, you're audible now.
Okay. Okay. Anyway, thank you, Dr. Vinod, for that wonderful introduction. And I'm really very happy, delighted, and privileged because the first time we tried to make this presentation, unfortunately, on my own, computer illiteracy, it did not work out. And thank you, Korut, my good friend, on all the friends in IEEE for your patience and perseverance to listen to me today. Now, what I plan to do is I'll just go into some basics in vascular surgery, then go on to complex situations, and then, of course, my involvement in the biomedical substitute, as the title says. Sorry, don't know. Now the title I have given, My Tryst with Blood Vessels, and of course more of vascular diseases, and then my interest and activities in the biomedical substitutes. As we all know, the heart is the pump, and blood is what provides tissues oxygen, metabolites, and the other fluid and the solid materials like RBCs, platelets. We all know the functions of all these formed elements. The supply is given by blood vessels. So these three components are important to keep the life on for all of us. Now, I would go on to some common things first, then go on to a little uncommon, the diseases that we treat. And coming to the animated diagram here, you can see the red lines show the arteries, the pure blood vessels, and the blue ones show the vessels which are carrying the deoxygenated blood to the heart for purification of the lungs. Now, despite what I have shown here, there are almost several kilometers of blood vessels which are called the divisions of arteries into arterioles, then capillaries, reformation as venules, and that is what the system joins carrying the pure blood into the tissues and impure blood back to the heart. Now, the vascular diseases can be classified, those occurring in the arteries, the pure blood vessels, by and large. But to some extent, there are some dangerous venous diseases as well. And then, of course, a mix of AV malformation, which is almost congenital. And the lymphatics is the fluid which gets stagnated in our body, which will be drained by the lymphatic vessels and the lymph nodes. Now that picture shows the normal artery on our left and the fat deposition and the cholesterol deposition, which is the disease process known as atherosclerosis. I'm sure we are all familiar with that disease, which in branches of aorta supplying the systems form the epicenter for the atherosclerotic material and the cholesterol material, thereby occluding the lumen and reducing the blood supply by directly leading to dysfunction and failure at times of such vital functions of any organ in the body. So that has to be identified and treated to sustain life. Now, the arterial disease can be steno-occlusive, but mostly for the aorta, that is the Mahadhamini we call, the big vessel which carries the blood initially, starting from the pumping chamber, left ventricle, right across to the upper chest, then the arch of aorta, then going on to the thoracic aorta, then below the diaphragm into the abdominal aorta, and at the level of our umbilicus navel divides into the leg arteries and arteries for the pelvis. So the diseases which involve mostly is steno-occlusive disease also in aorta, but by and large it is more of aneurysms and ballooning, and a 2 centimeter size or 2.5 centimeters size aneurysm in our body can balloon and go up to 5, 6 or 7 centimeter. At what situation it may crack, and then it can end in a very tragic event, a catastrophic rupture and death of the patient. So that's the importance of the aneurysmal and the ballooning procedure which happens. Now, I think some of the next slides, I think it will be interesting for all of us, because the two most non-modifiable risk factors for vascular diseases are male gender and age above 65. If the patient has hypertension or diabetes, then the age limit can start from 58, 60 and above. So these are the two non-modifying risk factors. But then below the mentioned ones are smoking, alcohol, diabetes, hypertension, obesity, less physical activity, thereby loading cholesterol all over body and vessels. These are the add-ons, and they worsen and enhance the difficulty of the disease in the blood vessels. So these are important. So that is why if you look at 10 patients, almost 8, at times 9 are in male gender. Of course, ladies have disease, but much less prevalence. Now, how do we investigate? Questioning the patient for at least 15-20 minutes, first time when I see the patient, is very important, because the patient comes with a problem. Patient has the answer within him or her. So you have to listen to the problems as they explain. Then, of course, we have to do the physical examination. Then a very important test in the vascular system is the known as angle brachial index. Angle brachial index means the blood pressure difference between upper limbs and lower limbs. It will tell us disease and blockade of the aorta, especially in the abdomen, or the lower limb arteries, which is one of the commonest term as called peripheral arterial disease. Now, the investigation per se is duplex scan. I think you would have heard of duplex scan or Doppler scan, which tells about the blood vessel wall, the content of it, and the blood flowing pathway, and any fatty deposition, the percentage of stenosis or occlusion, and is any ulceration, calcification, and so many details in a very active manner. Then, of course, the investigation that we always look for is known as the contrast enhanced CT angiography. I'm sure most of you will be familiar that there are some thousands of cuts of the body, and then they are united, and it's a computer reconstruction. It tells us, in a navigatory fashion, exactly what is wrong with the entire system in hardly about 2-3 minutes of time. The 128 or 256 slice CT, which we have in Sri Chitra, that can really, like without any damage, rip through our body and tell us what is wrong. Now, I'll quickly go into the control and management options in continuity with what I mentioned about the risk factors. The disciplined lifestyle is very important, by which I mean some amount of activities, and do not have smoking habit and alcoholism, hypertension, controlled hypertension. If in case the subject or patient has got diabetes, the sugar has to be controlled, and HbA1c, which is an altogether 3 or 4 months impact of diabetic status on the blood sugar level, HbA1c, if we keep it around 6 to 6.5. So it's very important being active, taking limited amount of food, especially after 40 years. So in Malayalam, I'll tell my patient, Midamaya Aharam, Midamayitingilum Vyayam. These two are very important. Disciplined life is very important. We can at least although we cannot prevent these diseases, we can attenuate the impact and the damage done to our body. Now, there are specific medications which I will be coming to. Once the lifestyle modification and the medications won't work, when the disease gets serious, or if the patient does not know and continue to have the risk factors, then we have what is known as angioplasty or stenting. Angioplasty is if there is a fat deposition and stenosis or occlusion in the blood vessel of say 90%, then the balloon can open up and push the fat back and forth, so making a lumen, and to sustain it, we will put a metal stent. Nitinol is the commonest we use. Then, of course, for the aneurysms, we have to do an open surgery, or we can do endovascular, what is known as aortic stent graft. It has to be a stent and a covering of polyester, so that blood has a new intraluminal pathway once we do the intravascular repair. Now, of course, open surgery is the last bastion, and that is taken when nothing else works or the patient's condition is pretty serious, and this has got also a big role in the treatment of vascular diseases. Now, there are 2-3 important things. Number one, when we measure the blood pressure in the upper limb and lower limb, if the proportion is 0.7 and the thickness of intima and media together, there are 3 layers, intima, media, and adventitia. If this relationship is more than 0.9 millimeter, this not only tells you that you are in for peripheral arterial disease or problem of, say, formation of stroke, it indirectly tells you that in the cardiac system, the coronaries, which are much smaller, 2-3 millimeters, their disease is started or starting. So that's the significance of doing simple technique of blood pressure measurement and an ultrasound. And of course, presence of peripheral artery disease also is an indicator, is a determinant of the atherosclerotic load, because it is said the atherosclerosis is a generalized disease with segmental predilection, where at branches and the arterial origins, there is more fat deposition. So if we have, it's a common finding in the clinics that we do, peripheral artery disease, the leg vessel involvement, the carotid arteries, that is the blood vessel in the supplying the brain in the neck, and the coronaries supplying the heart, all 3 are existing simultaneously with differing or diverging levels of difficulties. And the patient may come with one, but they may be harboring the other 1 or 2 in their body. Now, quit smoking, I think one must. Then, of course, as I mentioned, diabetes and hypertension should be controlled. Then, of course, diet discipline is physical activity is very important. After 40 years, we have to cut down our intake of diet to 50%, because our growing time is over. We only grow broader, put up a belly, put up a lot of fat in our mesentery and inside all over the body, which is a harbinger of disease for us. Now, antiplatelets, we know the platelets are small particles about 7-8 microns in size in the blood to prevent bleeding when there is a cut in the body. So we need antiplatelets, because platelets, there's a tendency to clump together and create problem and form big clots, and statins are for anti-cholesterol medications, and silestazol is a phospholipid inhibitor, phosphodiesterase inhibitor, which improves the patient's walking distance for the peripheral arterial disease. Now, these 2 I have already mentioned. When things go worse, angioplasty, stenting, and of course bypass surgery. Now there is a new term called hybrid procedure. When we mix open surgery with the endovascular, it lessens the stress on the patient, and that can be very beneficial. Now, what I am going to discuss now bigger diseases like stroke, which is because of the carotid disease, fat deposition, peripheral arterial, I already mentioned, abdominal aneurysm, when the atherosclerotic material enters or forms a thinning of the media of the aorta, it can weaken and balloon, so that at some stage 5.5, 6 or 6.5 centimeter size of the balloon aorta, there can be cracking, and that can be very dangerous for life of the patient. So it's important to control the blood pressure, other factors, plus consider intervention or open surgery or endovascular surgery. Then thoracoabdominal, much larger. Endovascular is, again, I'll be talking about in my biomedical substitutes about this. Now, this is an interesting picture to tell you how nature, despite those yellow arrows show that the segment which is seen very well clearly on the right side of the patient, it is missing, but despite what is known as collateral flow, patient can walk. This patient came to me. He said he used to walk 2, 3, 4 kilometers, but last 3 months, 4 months, he can walk only about 100 meters or 1 or 2 furlongs only. He has to stop. But then looking at the collaterals, I opted for medical management. Now he's back to 2 kilometers. So it's not always that a lesion needs to be treated, but it has to be decided on a patient-centric way. What is best for the patient? Then choose the best for the patient. We should not be treating the lesion, which is just an incidental problem. Moving. Now, this patient was shown to me after getting plating done for her fracture. Second time, And then what was found that she could not move the limb. The pure blood vessels supplying the thigh region and lower got caught. And the CT scan showed abrupt cutoff. And I was called in to do the surgery and remove the clotting and give a bypass. And then we found that is the just above the knee area. You see that the vessel is very deep, very obese patient. You can see in the between the silk threads, the artery is open. There's no blood coming, and it's a clot there. And that's the clot I removed from below the knee. And we took the vein from the opposite leg and arterialized, and patient had a very smooth recovery. Now this is the duplex scan which shows good flow. And this is another patient, 75-year-old man who was diabetic and hypertensive, had coronary stenting. He came with no pulses. He could walk hardly less than a furlong. You can see that the red arrow showing about 80% stenosis. We could do an angioplasty followed by a stenting, and then the artery became almost near normal, and he is doing well. Now, there are problems when things get worse. You can see the yellow arrow above and below shows long segment occlusion of the leg artery in the abdomen and somewhere below the knee joint also. So this patient, there's no angioplasty possible, medications only. He had a blue color and an ulcer in the foot, continuous pain, and the leg was facing probably an amputation. So that tells you that this left-sided, the blood vessel is totally blocked. You can see that in the abdomen, we have stitched a polyester graft at one end, and then taken it, this much area was removed from below the leg, and then we have come to the groin area and connected the polyester graft. And the patient's limb survived. Now I'll come to the treatment schedule called carotid endarterectomy, which talks about the stroke prevention. It is stroke, as we all know. We would have had some our grandfathers or relatives. They are not able to move a hand or leg. They are bedridden. They are not able to speak. So to prevent this, we do what is known as the endarterectomy. Remove the entire plaque and modify the vessel so that there is no plaque there, and blood flow is also come back to normal. This is the history of how we all started. Then this is our team, Swasti, working for stroke prevention. And people will come with symptoms of, say, sudden blindness in the eye, or transiently 3 or 4 minutes, their arm and leg are paralyzed. They cannot hold a glass. They cannot walk. And there are much more, of course. They can even develop a dense stroke. And we have a protocol to treat them medically. And this examples you will be able to appreciate. On the left side, you can see that that area called the bulb of the internal carotid artery, which is going straight to the brain, it's almost 80% stenosis. We removed the cholesterol material, put his own leg vein, and I think this patient I have done about 10 years back, and he's doing well. There's another headmistress who was diabetic and hypertensive after retirement. You can see a hairline continuity, and that same operation of endarterectomy, you can see below that yellow thing, the common carotid artery continuing as the internal carotid to the brain, and it's almost a cure for the patient. Then, of course, there's another. You can see the red arrow shows an infarct in the brain. That is, the artery supplying that area was blocked. His left hand, that's the right side, left hand could not move for 1 week. Then he came to me because somebody tried a stenting. It was not successful. And I operated. You can see that the brain artery, which is hypoplastic, I would call it, is thin, and it's just continuous. So what we have done is we have done further testing, and that is the carotid artery in the neck, and then that is what we go from. On the left hand side, the whole plaque is in continuity. On the right hand side, you can see the debris, like sand particles, like blood clot, which travels to the brain, obstruct the blood flow, leading to stroke. And he is now doing well. He's a professor in Angamali, or Kaladi University. Now, I don't want to go into these details. Totally, I am fortunate in Sri Chitra, I've done 285 and 10 in SUT. And last 100 patients, all of them, we could prevent stroke. But 2-3 patients, they have had minor stroke, but recovered at the time of hospital discharges. But these are difficult procedures, and very difficult for patient to go through, because if they are not able to walk, they're bedridden, they are not able to speak, I think life is very poor quality. Some more pictures of the procedure. I think this we use a carotid shunt, and that's the role of engineers, which I'll be coming. While we see the vein patch in the picture on the right up and as well as the left one, those will be, the shunt will be positioned so that the brain gets some blood supply, and then we remove the shunt when we are putting the last switches. And that again is the shunt pressure. This again upper side on top, you find that post-operative picture, and this is a lower down that angiogram, carotid angiogram shows 12 years after carotid endarterectomy, in which patient the opposite side had got blocked. He is doing quite fine. Now, these are the other plaques which we have removed. The bottom left shows the carotid shunts which we use. One end will go to the common carotid, another to the internal carotid, so that as we do the procedure, after removing the plaque, of course, then some blood goes, not the normal way, but at least definitely there's some perfusion, so brain is not totally ischemic. Then, of course, I'll quickly go to the abdominal aortic aneurysm, which I described. These are not very important for an audience like you, when we choose, but what this slide is important. In abdomen now, mostly we do open surgery, and the endovascular transluminal procedure we do much less, whereas in the chest, because many patients are 70, 75 years, elderly, they may not withstand a major surgery, they will have some renal problem, kidney problem, cardiac problem. So there we use intraluminal procedure called hybrid procedure. That round thing, like cut section of an egg, which shows that the inner side is what is known as the luminogram. That's a normal size which is ballooned up, and this patient was operated, and it's a cure. Like on the right side, similar picture. This picture on the left is the aneurysm, which is bulging, ballooning. It's quite likely in the following months, it can crack and rupture, and that bifurcated graft polyester material, we have put it inside, and we'll wrap the aneurysmal sac, as it is known, and then the patient, such procedures are almost a cure, if I can call it. Now, the thoracoabdominal aortic aneurysm, I don't want to go too much in this. I've done about 128. These are the most stressful procedures ever described in the literature for surgery, and these are the classifications. This one, if you notice, this is a patient I operated 20 years back. Even last 2-3 years back, I've seen him coming follow-up. You can see that the round thing on the top right is an aorta, which is normally 2.5 centimeter, grow to 10 centimeter. Actually, he forced me to operate about 15-20 years ago. He's living, and his heart is compressed there. He's doing quite well. This is the big procedure. You have to open the chest and abdomen. Difficult to even watch it as such. This is the entire aorta is replaced. And this is the carotid shunt, use of carotid shunt to supply blood to the bowel vessels as well as the renal vessels, so that as we do the surgery, they are not totally devoid of blood flow. These are some other procedures going on. And the endovascular we are doing in the chest, and the abdomen we use mostly open. And these are the some of the procedures. This is how the post-operative check CTs show. On the right-hand side, you can see the carotid vessels, upper limb vessels. They are revascularized by using a prosthetic graft, and we have put 1 or 2 grafts on the right side, 1 graft on the left side, so the aneurysm is treated. I'll quickly go to what is known as an aortic dissection. Dissection is important because some small subset of patients who come with chest pain may not be having cardiac problem. They may be having hypertension for a long time, and there can be a tear in the inner lining, blood seeping through the media of the aorta, and that can lead to what is known as aortic dissection, very serious life-threatening situation. And those are the pictures there. You can see the tear in the aorta, and some of the pictures we have treated with what is known as the hybrid procedure. You can see that after the tear, blood is leaked into the chest, and we have done the hybrid procedure and drained the blood. these are some other operations. This is known as when someone has got a severe chest pain and cardiac enzymes, ECG, TROP-T test, CPKMB all normal. We should suspect a pulmonary embolism, that is the blood clotting from the leg and going to the lungs, or it can be because of the aortic dissection. Now, the increased incidence of vascular disease are noticed these days, especially in elderly 80 years and above. An effective intervention surgery is available to save life and organs and limbs, then it definitely improves the quality, and we are justified in having the full-blown treatment schedule in. We had it in Sri Chitra Institute. We continue to have there, of course, and the same treatment is available in SUT Hospital. Now I'll show you one video of a balloon abdominal aorta. What I showed you, it is the aortic aneurysm. That's Achinomenon Center. This is the lush green biomedical center in Sri Chitra, and that you can make out. Above two ones are the spleen and both kidneys, and this is the aortic aneurysm. This is mandatory. You can see that pulsatile pulsation with the heartbeat, and that aneurysm we are going to show you in the operation. It is so big, almost for a length of about 10 centimeters, and the whole abdomen is open. I'm sorry, I hope it will not trouble you. You're able to see it, isn't it? So this, just to tell you quickly, 2-3 minutes, that's the large bowel, we lift it upwards, and then the small bowel we lift to the right and little to the outer side, and then that is the aneurysm which we saw in the video. And then we have to get control of the upper segment, which is normal. Go for the near the umbilicus, where the aorta divides into two, both legs. That we control it, and then we have to. The dissection is a little difficult because the bowels keep moving in, and then we need assistance. And we are that's what we do. This what is known as a test clamp, the special equipment clamp, so that we have to completely stop circulation in that area for the legs also for about say 1 hour or so as we suture this polyester graft. This is getting the control of the leg vessels here below, and that is the polyester prosthetic graft. This is what will go, which is about 18 to 20 millimeter. That's what is only required for blood circulation in the both limbs. So we stop it after giving blood thinner heparin, and put two clamps below in the leg vessels inside the abdomen, so that the blood will not come backwards. And we open the aneurysmal sac, as we call it. He is monitored with arterial blood pressure, central venous pressure, then the urinary catheter. See, that much is the layered thrombus inside the blood vessel, which keeps on thinning. So some small blood vessels are there inside the aneurysmal, that beginning of the aneurysm we call the neck. We have to suture it so that it does not bleed now outside the graft. So we are fashioning what is known as the neck, the beginning of the aneurysm, and we take what is known as the parachute technique of suturing, getting sutures on the graft, and then we take at that cut area, so that the graft is incorporated now to normal aorta. And then parachute is, we take 4-5 and then anchor it like a parachute. And this is the end point where we put a pledget, so that the tissues which are not extremely healthy, they don't cut through. And now the graft is sutured down, so that now instead of the aneurysm, blood is flowing through this blood vessel. Now this is a very stressful period. We have to remove and make sure blood flow is there. There is no leaking from the graft which we have sutured, and then come back to the aortic bifurcation. Tissue will not be very healthy, but that's all we are given, and we have to appropriately strengthen the graft a little, and then modify the length so that we can. So now that is being cut off. Although initially we take a little more, we cut off and make it appropriate, and this graft stretches a little. It's called crimped graft, so it can stretch a little. and that is taken with what is known as a polypropylene switcher, which is a switcher which is non-absorbable, and it stays through the life of the patient. It is not absorbed because it cannot be absorbed because aortic blood pressure is coming. Here also the multiple switches are taken and the throws are seated, so that now that is anchored there. This requires a good deal of experience to operate, because bleeding is a major problem, and if bleeding is not occurring, you have a sound system of suturing, then the patient's life is settled. Then the other problem will be that they can develop a cardiac problem because it's a stressful procedure. So we make sure that the heart angiogram is done and patients are assessed by the cardiologist, that heart will substantially undergo the surgery safely. If that is not possible, of course, the tail end of this video, I'm going to show the endovascular aneurysm repair through a keyhole procedure, keyhole incisions in the both groin. And then you don't have to open the abdomen, you don't have to do anything. Now both ends are sutured. Now the aneurysm is treated, and then we are wrapping the aneurysmal sac, which is so big, so that we form a shirt-like bone tissue. So the graft is not exposed to the bowels, and bowels don't scratch on this and produce any damage. And that it is better to bury nicely under the tissue, so that the aneurysmal sac is not sutured. Now a brief 30-second video of the endovascular. That is a marker pigtail, that is to measure each one 1 centimeter, and then we appropriately go by the size of the graft, sizing of the aorta. 2 centimeters above the aneurysm, we have to seat it like a parachute. It opens. Now it's open on the aortic side and on the right side. Then there is a gate on the left side, and for that, from the left groin, we'll put in another graft. So simply said, in about 1 minute, it takes about 3-4 minutes to do it. But when patients are more than 75 years, they have cardiac problem, their lungs problem, or they have got renal problem, then we have no choice. We have to do this endovascular procedure only. I think these numbers are old numbers. Currently, I have done about 365 open procedures and 20 endoaneurysmal raphe, because that's all we can we have to do, because the endoluminal graft is 5.5 to 6 lakhs. Sorry, I'll just go out and click. Can you close? You're going to close here.
Not this one, another video.
Okay, now I think this section will be very interesting for engineers, because in vascular surgery and in cardiac surgery, the entire gamut of improvements, devices have been because of a close association with electro engineers, and the combination of doctors, surgeons, and engineers have produced now artificial heart, vascular graft, cardiac valve prosthesis, which is Chitra valve has been put in more than 1 lakh patients in the last 20 years. So we have fibrin glue, we have small vessel graft, we are even making aortic stent graft indigenously, so that the cost will be less for the patient, and they can go through the surgery with less amount of money. Now, this is my mentor, Professor Valiathan sir. He's Padma Vibhushan. He is our source of light and encouragement, and everything that I have mentioned so far, and what I'm going to project, it's all as a result of his teaching. Now, when clinicians identify a problem, what happens is there is a beginning of an idea of implant and devices. Are you able to hear me? Are you able to hear me? Yes. Are you able to hear me?
Yes, sir. But
Yes,
somebody
sir.
is speaking in the background. They have to mute.
Okay. So the clinician has a problem, has an idea. He has to have an idea, then work with the engineer. So the beginning of implant and device development starts, and it has to be tested, like the material has to be tested for
Prasad has to mute.
biocompatibility, then the thrombogenicity, whether we can accept it in our body. Then, of course, they have to go through a lot of laboratory testing, then evaluation in vitro. Then it has to go through small animals and large animals like sheep or pig. Then, of course, at the end of it, once you have proven the device material, device activity, we have to put it through ethics committee headed in Sri Chitra by a retired High Court judge. Then we have to go for controlled clinical trials in the institute which is devised and developed it, and go for proving that things are really good and not harmful for the patient. Go for multicentric trial. Then, of course, you have to have a follow-up of 2 years. 2 years minimum, ideally 4 years, before the product comes on the shelf. Now that is the Chitra vascular graft for the open surgery, that pearly white graft. You can see it was developed by Citra, that is South India Textile Research Association, Coimbatore, and they're part of Lakshmi Mills. And then we have done all the testing and the human implantation. TTK has taken the technology transfer. Polyester graft, it's a polyethylene terephthalate, and we are available at between 8 to 30 millimeters. They have a porosity needed for healing. This is in the pig which I have implanted some 20 years ago. You can see that the normal aorta is excised and put in place the Chitra graft. And then we have explanted it at 1 year or 2 years. You find the inner side is absolutely pink, like endothelium, normal endothelium. And there's nicely endothelium is grown, accepted in the body of the animals. So we are ready for using it in man. This is in one man. And this is another patient who is received for coarctation aneurysm. And then, of course, the porosity were closed by what is known as hydrogel sealing. That's again by our eminent scientists and engineers in biomedical wing. They have done it. And then we have used this hydrogel to seal. That's various number of tests done: toxicity, pyrogenicity, hypersensitive reaction, delayed problems, all that in small animals. Then we have to coat on the graft. Then these are the mechanics for the coating the graft, and that's what happened. Then ultimately we have to test in pigs, which I have shown like the first one. We have done 30 pigs and proven that it really works. These are some of the experimental work we have done. You can see that bottom, the part of the Mahadhamini aorta is excised, and we have done the interposition graft there and proven that no bleeding is there. This angiogram on the right side, which shows the suturing is good, no leak, and you can see the crimps, fine crimps, and the graft in place. This is after explantation. We have found very smooth neointima, no blood clotting at all in that. It's accepted. You hear also much larger graft. And this is the histopathology. I think this takes about 15 years or so for multicentric trial. And then this is in European Journal, we put in 15 years after Chitra graft implant. We have 2 articles in the Indian Journal of Medical Research also, and PubMed indexed. And now this one is the aortic stent graft I have been talking about and that is where the aortic graft at the front end, and this is the delivery system, and this is
Slide is not moving.
small groin incision, and the whole device goes. This is the aneurysm which is bulging. We make an incision in the groin, and the prosthesis goes.
Just check 1 minute. Slide is not moving.
അല്ലെങ്കിൽ I have വേറെ പിക്ചർ ഉണ്ട് എനിക്ക് വേറെ അതിന്ന് കാണിക്കാം അപ്പൊ അത് നമ്മള്
No, it is not coming.
Just once.
Video മാത്രമുണ്ട് animation. ഇതൊന്ന് stop sharing and ഇത് close ചെയ്തിട്ട്.
Just to show it without going to full screen. Now you can even tell without going to full screen.
Okay. ഇപ്പോഴും പോകുന്നില്ലല്ലോ. വേണ്ട, എനിക്കിവിടെ കാണുന്നില്ല. ഇതാണ് ഒരെണ്ണം കൂടി ഇവിടെ ഉണ്ട് കാണിക്കാനായിട്ട്. ഞാൻ വിളിക്കാം. Can you see now?
Yes. Now it's okay.
Okay. So that is the delivery system, and at the tip of it is the graft, which is now crumbled, and we take it whichever part of the aorta. That is the aneurysm in the just after the arch inside the chest. The aneurysm is now the aorta is bulging and may rupture if you don't treat. So it's delivered through the leg artery in the groin, and before that we put a stiff guide wire that will be guiding the graft there. We go a centimeter or two ahead without blocking those neck vessels and brain arteries, and then we make an anti-clockwise twist in the delivery system. And you can see that this is I mean, this is now the new blood is going through this new lumen. So I think I'll go on to the. Go into the. Ayurveda, what we'll do? Can you hear me now?
Yes, sir.
Yes, sir.
Okay. Now I think this is an important few slides that I have. The aortic stent graft in the making, and there's a big team working on it. I was part of it in the beginning when we started, but now after retirement, less of involvement except some discussion. And Sujesh is the head of the engineering team. They are doing good work on. So the design is, it has to have a polyester graft material, and then the metal stent has to be there. It's called the nitinol, nickel titanium alloy, so that the graft doesn't collapse, because we are not suturing it. It is placed at least an inch above and below the diseased area. So it stays by oversizing and axial force. This is the one here. This is not moving. Okay, one second. I think I'll just ഇതിന്റെ ഒരു നല്ലൊരു വീഡിയോ ഉണ്ടായിരുന്നു ഇതിന്റെ അതല്ലേ കാണിച്ചപ്പോ ഇതില്ല ഇത് Now that is the stent graft that we have made. You can see that multiple rings and the polyester material. First we have to, this is the ultimate size. We have to crimp it. This is instrument that is indigenously made by our colleagues there. So it is passed through the machine. So it crimps and makes it small to get into the leg artery. Because such a big artery in open stage cannot enter through the leg artery. So that is the crimped artery there, crumbled, or I would say, and that is now mounted in the delivery system. You can see that there is a small area of 1 centimeter. It is about without any Dacron polyester graft, because it gives an additional proximal catch on the aorta, because we are not suturing it. And then that's an just to show what exactly we are planning to do. We have to go about 1 centimeter to a head, and now see, slowly when you do the mechanics on delivery system, it opens up and comes to its original size, and now the blood goes through only the stent graft, and the patients survive, of course, and they survive more than 10-15 years, and these are all done in extremely aged subjects on patients. So a 10-year, definitely a 10-year life is very, very good for them. One more video is there. So I think I'll conclude with one video, one personal video. I am grateful for all the members for giving me this opportunity. CAROTID for this wonderful chance, but I don't know. I think there's too many videos, and this thing are not kind of playing proper. കാണുന്നുണ്ടോ?
Dr. M. Unni Krishna in the category to recognize the merit of an eminent medical teacher.
Actually, this was the result of a whole team and the whole Chitra family. And I think with all modesty, I'm grateful to so many of our mentors and colleagues. Stop sharing. So once again, I thank all the members, eminent members of IEEE. Sorry for I'm unable to put this. I have seen several times, at least 10 times this video last 10-15 days, but ultimately at the moment of truth, despite help, it is not coming in a very good way. And thank you once again to all of you, particularly my Guru. It is a great opportunity, but also it exposes my illiteracy on managing computer and presentation. Generally, I only present 8 to 10 minutes without any video, because videos are difficult to play with. Anyway, thank you very much. I'm very happy to be part of this meeting. Thank you, and really it's my privilege. Thank you.
Thank you, sir, for your wonderful presentation along with a lot of case studies. So now I think we can go for a question and answer session. There are some questions in the chat box.
Thank you so much. That is not coming full.
Yeah.
I think, can you come here or should I come that side?
Let me, I will raise the questions one by one. There is some opinion from cardiologists that 8 out of 10 angioplasties are unnecessary. Please comment.
I disagree with that because what happens, I can start telling you a story. Dr. Abdul Kalam, the prestigious president of India, to Assam, he went to address the students. He was running in the airport, going out and walking 200 meters. And while he was presenting, he dropped dead. Many times, the cardiac blocks in sedentary life may not present any problem. With some minor stress, it can be something enlightening. So I feel if I have a serious problem like 80%, 90% stenosis, there's a good chance I can have a heart attack at odd time, and then please comment. So I don't think angioplasty, especially if the patient has got symptoms and the 70 or 80% and more in the beginning part of blood vessel, I think angioplasty is done. Sometimes I think when it is happening to your neighbor or somebody, you feel it's unnecessarily. When you have it with the fear of dying and not seeing next day morning, I think you run to your cardiologist for a stent. Then regular intake of 75 mg can prevent cardiac problems. That is not absolutely true. What happens is, what prevents, as I explained, there are two non-modifying factors for any vascular disease: age, male gender. So you have it if you are a man 65, 70 years. Now, if you are on ecosprin, the propagated thrombus and the tendency for thrombosis in and around that vessel, which is the culprit, will be reduced. So there will be some time to go to the doctor, and it will not clot off, and it may prevent sudden death despite the event in at least a good percentage if somebody has been on aspirin, statins, and control of risk factors. May you once again tell about the vascular issues are more in males? Why? I can't tell you this. That is the statistics world over. Globally, it is found in males is more. I think some factors like the protection of estrogen and as at least the ladies can be patient and they can be, perseverant, and they don't get angry like man, because anger means it's a momentary madness. My BP may go to 200 if I unnecessarily, many times I'm angry because it's my mistake. So I will want to push down my wife and say that you did that way and that's why suffering. I think what we have to do before responding anybody, count till 10. Then you sort of modify your answers, and don't be impulsive, and keep close. And I think that's what we should be doing. That's why in males mostly, and ladies are perseverant. They look at broadly. They never look at their interest. They look at the family interest. And husband, I think he has multiple things. Family interest, his own personal interest comes at least about 60% as compared to 40% for rest. That's what, personally, my own feeling. That's what you see all over the world.
Next question actually whether it is can be seen on YouTube again. Okay, it's already been recorded and streamed in YouTube. The link is also given in the brochure.
I think the clot can be of two ways. One, I should say three ways. The artery can be having a clot suddenly because there is a clot which travel from heart or aorta and block suddenly, acutely. There, if you don't take it out, what is known as the golden ischemic time of 6 to 8 hours, remove the clot and re-perfuse the leg, that leg will be amputated, number one. Number two, if an elderly person like 70 years There's been a small buildup of cholesterol, and then there's what is known an acute on chronic event in that ulceration or a clot formation there. It can lead to, and if it's not attended to properly, it can lead to amputation. Then having a clot in the vein is a different proposition. It's because of somebody is on total bed rest, somebody has some paralysis, somebody had a fracture with a plaster cast, and somebody has got a stroke where the movement is less, the muscle mass, there will be vein clot. Vein clot, I think it will lead to pulmonary embolism when it migrates, but it will not be leading to a loss of leg. There will be edema, there will be a lot more chronic situation. This, I think, in your sister's case, it must be either an acute embolus from elsewhere, blocking suddenly, or an acute on chronic event because of atherosclerosis, diabetes, and hypertension. And there is a exponential increase in the size of the clot, and proper or appropriate or timely treatment was not forthcoming. Good question.
Now, next is from Shine. That is, is from IST Trivandrum. Is there any effort in Sridhara regarding computational modeling of the degree of stent size, shape and location, and their effect on the flow resistance, reservoir, wall shear, stress, etc.? And again, we have seen one more question.
No, once I think I answered this. In fact, you know, the coronary arteries are special for several reasons. One, size is 2 to 2.5 millimeters in size, number one. Number two, in when heart fills blood in diastole to contract and give blood to the entire body, there will be lengthening and shortening. There is a what is known as a vascular motion. So many stents can misbehave because it is stretching and collapsing. Not to a great extent, but to some extent. Same story with the thigh stent also can happen. So that is why, and then there is a technique called intravascular ultrasound. Visualize on the television. Am I audible there?
What marches are they?
So kindly mute your
Some other sound is coming. Can you?
Okay. Can you hear me?
Somewhere else, can you?
Can you hear me?
okay. Now you can.
So I think the IVUS is a new mechanism where we can visualize the lesion, the fat deposition, cholesterol crystals, see the passage, it's regular, it's ulcerated, the endothelium is damaged, or the stent is sitting pretty, so that can be done. But the computational system, I think that has to be developed, and that's a very high-tech engineering question. I don't think I'm competent to answer that. Sorry.
Similarly, regarding aneurysm initiation.
I will ask one more question. Hello.
Yeah.
See, there's I had a very painful incident in my family. My sister-in-law had an angioplasty in one of the hospitals here in Nagpur. And she had a clot on her leg, and her leg had to be amputated. Is it because of mismanagement or something else? Can you say? Mismanagement, is it mismanagement?
No.
Blood clot on her leg result in ultimate amputation due to angioplasty.
Actually, it's very difficult to make a comment on from the history alone, but there are few things about the atherosclerosis. Atherosclerosis is a generalized disease with segmental predilection, and most of the domains where disease comes is the leg arteries, the groin downwards, the heart arteries, and the brain arteries. They may coexist with varying proportions. So if the puncture site had disease and they had to pass a stent, and then it has go through that area, or some plaque is traveled downwards, that could lead to, so I think an existing disease would have been the precursor, but I cannot give a comment exactly why it has happened. I think only it's context oriented. Only the doctor can tell what's gone wrong. Is it patient factor? Is it a procedural factor, or combination, or inadequate medications, But it is a sad event. After a coronary stenting, the leg is lost. It's a sad event.
What is it to done in a private hospital? You know, the angioplasty is a big business over here. That's why we're asking. First question was 8 out of 10 of the angioplasty is very often unnecessary, and by medication it can be reduced. So when somebody goes for a angioplasty without any reason, this can happen. That's what I'm telling.
No, one thing is that if the patient has got chest pain, if the patient has got severe breathlessness, and if he has got if his quality of life is restricted, especially breathlessness and chest pain, if he has got, then angioplasty is required, because that's the beginning of a major heart attack where the heart can suddenly fail, or it can fail slowly to form what is known as severe cardiac failure. If supposing a block is seen less than 70% narrowing, I think medication should be enough. More than 80%, it is better to stent it, because anytime it can collapse and fail. So I think it is. I think it will be a crude idea to tell 8 out of 10 are unnecessary, because if a heart block is found 80% or above, even with minimal discomfort, I may go for stenting, because if it shuts off completely, I may have a heart failure. I not survive. So I think, but I do agree. Many. There are several.
That's all the hospitals follow that. A protocol for this.
Yeah, I think
it's very arbitrary. Sometimes the decisions in private hospitals are done arbitrarily, and it's a big business. It's a big business. I tell you, it's a big business. I don't say it will happen in Srita or some government hospital. It's a big business in the private industry, angioplasty.
Anyway, I cannot fully agree with you. There may be some individuals or individual places, but I feel that still physicians will look at the block and look at the severity and the symptoms.
So can we go to the last question?
Not the money, not the money. Okay, I hope. Okay.
So
thank you.
Can we use the 3D reconstruction of vascular geometries from patient-specific MR or CT scan data in understanding the changes in hemodynamics parameters?
Actually, yeah, I think to some extent, hemodynamic parameters are clinical examination and angle brachial index examination, even simple blood pressure and duplex scan. And what is required is the size is the determinant for rupture, and the layered thrombus and the branches in the vicinity which are originating, because in endovascular, as I mentioned, at least more than 2 centimeter or 3 centimeter beginning and end also has to be closed off. So there, I think all this volumetric study and all will be precise location and understanding will be helpful. Hemodynamics is not so much.
Okay, thank you, sir. So let me invite Dr. V.S. Manal, sir, Chair, IEEE IEEE Kerala Chapter, for presenting a digital moment. Doctor.
So it gives me immense pleasure to give away this virtual memento to Dr. Marthipat Nikishan as on behalf of IEEE EMBS Kerala Chapter. Sir, please accept this virtual memento, and you will be given a physical memento in office, IEEE office. Very glad to have you here on this particular occasion. Learned a lot from you. Thank you.
I should thank you for the persevere and patient, and Korit for his efforts, because when I came here, I was zero at computers. At least at home I could do something, because I mean totally dependent, and mixing 4 videos in a presentation, things could go wrong. Generally, I don't attach videos, because I've seen people struggling showing videos and it doesn't open. Then it is, you get upset, you can't present. But since already I got a little disappointment last time, now my threshold is increased, so I could go through this.
Yeah.
Anyway, thank you for this opportunity.
Yeah, thank you.
Sir, Guru sir will be giving the actually that hard copy of that memento to Dr. Nikishan sir. The same is actually giving to Dr.
Thank you.
Now I welcome Mr. Koruthi Varghese, Chair, IEEE IEEE Kerala Section, for presenting the vote of thanks.
Yeah, very good afternoon to all. Dear my members of LMAG and members of EMBS and all those who are present here. A very good afternoon to all. First of all, I have to say an apology for starting it a little late and closing it a little late. This, you know, because of our a little technical problem. I hope everybody enjoyed the talk as well as enjoyed the video. By seeing that video, you know how doctors or engineers are going together and their work. This particular program is organized jointly by EMBS and LMAC. And first of all, let me say we are really fortunate to have Dr. Unnikrishnan here to give this talk. Actually, Dr. Unnikrishnan is a professor of Srijitra, and moreover that he is a very good friend of me and a very good and moreover a very family friend. Because Unni's children and our children goes together, they all call them Unni uncle, so I used to call him also as Unni uncle. So he is our Unni uncle. And he is, I know he is quite busy in most of the time. It is very difficult to get him. When I called him, he agreed and he came and given the lecture. Thank you. Thanks a lot, Dr. Unnikrishnan. Thank you. And next, without any technical talks, we need participation. Nowadays, every hour there is a webinar. So at this busy time, most of them has found time and came, attended the webinar, and a special thanks to all of them. But when I am looking into the members list, I found some new members. I know that you are interested in this one. If you can let me know your mobile number or email number, I can send it to you the next information also. So once again, I wish to thank all the people who worked behind this program to make this a good event. Thank you all. Thank you very much.
So with this, okay, we can dispatch the meeting. Thank you, sir. Thank you, everyone.
Okay, thank you. Anything, Vinod? Okay, thanks.